Hello, everyone. Welcome to today's webinar with Mingle Health. I'm Charles Howes, your host today. Our topic is the 2022 final rule and the end of web interface, which particularly impacts APMs and ACOs with your quality reporting and navigating these CMS requirements to earn those shared savings. By way of introduction, if we're new, Mingle Health seeks to be your trusted partner in a transition to value-based care. We help you improve what matters, focusing on improving quality scores while saving you time and ultimately increasing earnings. We'd like to thank our partners, clients, and all of you and frontline healthcare workers for all you do to respond to the COVID-19 pandemic. Since 2012, we've helped clinicians and group practices and healthcare systems succeed with the quality payment program. All of our solutions uniquely combine technology and advisory services to help organizations remove the burden of these programs and maximize your financial incentives. Some housekeeping items before we go ahead and get started here. This webinar is being recorded. The slides and recording will be sent out later this week by email. You can also take a moment right now to download them in the handout section of the GoToWebinar panel. There, you're also going to find the chat box. There you can submit questions throughout the webinar. We've left plenty of time at the end to hear from all of you, what challenges you're facing, feedback on the content. So please do take a time to think about questions you have and get them in so you have an opportunity to ask our experts today. Just a reminder, if you haven't already, check out our resource center on our website, where there's lots of resources, guides, webinars, videos on the quality payment program for MIPS and also for ACO reporting. And most recently, the primary care first program, which is like an ACO in a box for a single practice. So definitely check out that program if you haven't learned about it yet. Now let's go ahead and jump into our presentation. I'm excited to introduce our presenters today, our subject matter experts. First is my colleague, Allison Casaccio. She's the Vice President of Client Services here at Mingle Health. Both Allison and Amy are gonna pop onto the video here in a moment. Allison is a nurse informaticist by training with experience in several different EHRs. And in addition to EPIC certifications, she's also trained as a change acceleration process and executive coaching. I mix that up, Allison, but essentially you lead our consulting team to make sure folks are achieving their goals and succeeding with the CMS program. So wonderful to have you here today.
Thanks. Welcome, everyone.
And second, but not least, is my colleague, Amy Landry. She's the Manager of Client Services. She's been on the team since 2015, and it manages a team of consultants who work with our customers to help them navigate PQRS and now MIPS and the quality payment program. She's also our expert on the APM Performance Pathway and is working to guide the ACOs that we serve to make the transition to all payer reporting. She has a background in marketing and over 20 years of sales, training, and consulting experience. So welcome, Amy.
Thank you.
All right, let's go ahead and take a look at what we're going to dive into today.
All right. So today we're going to discuss the significant changes that the 2022 final rule, which was just published on November 3rd, brings to those of you who currently are using web interface reporting methods. We've been talking about this topic and how Mingle Health can help since the proposed rule was released, but now that it's finalized, some of the up in the air questions have been resolved and we can help everybody gain clear understanding of what you actually need to do at your organization. We're going to talk about who this impacts, give recommendations for how you can best prepare, talk about data aggregation, talk about the methodology that's going to work for those of you with multiple EMRs, and of course, tell you what we can bring to the table should you decide you like our assistance. We're also planning to leave time for questions. So if you have some now or as we go, like Charles mentioned, don't hesitate to pop it into the chat box and we'll make sure that we get to them. Before we jump in, I think Charles has a quick poll for us.
Yes, just to take the pulse of where you all are right now, We would love to understand what you foresee as your biggest challenge in making the transition from web interface to using the MIPS clinical quality measures or the electronic clinical quality measures. So please do take a moment to share what's on top of mind for all of you. Just a few more seconds here with the poll. And if it's not relevant to you, feel free to just skip it. We'll share the results back in just a moment. Got about 30% of you voting. There's no wrong or right or wrong answer, so no worries. So we're not going to hold you accountable. We just want to know what to kind of, spend a little extra time on in the Q&A and weave through our presentation. All right. Wonderful. So I'm going to go ahead and close out the poll here in 5 more seconds. Thank you all. All right, and sharing back the results here, combining data from multiple EHRs, not surprising, particularly with the way the measures work. So we're going to spend a lot of time on that piece. Also, the reduction in quality scores came up next, but close behind is documentation and workflow variability. So all key items to understand and be on top of in this transition. And I know Allison and Amy have stuff to share, insights to share on that. So let's go ahead and dive in.
Sounds good. So let's talk a bit about what exactly has changed. We know that the changes are the direct result of, like I said, the 2022 QPP final rule, which was released November 3rd. These annual rulemaking updates are actually always a source of excitement here at Mingle Health, as our subject matter experts dig into the 2,000+ page document and analyze and interpret what CMS did in comparison to what they talked about doing in the proposed rule. Now, CMS does publish and respond to additional public commentary, so we also encourage organizations to join us in submitting comments during the open comment time, as it's certainly one way to influence the changes being made and discussed. Today, we're really going to be focused on the end of web interface. And for those who aren't aware, CMS has given ACOs a little more time to transition to MIPS CQMs or eCQMs because they recognize that there'll be some effort needed to make that change happen. Remember, CMS's goal here is to streamline and standardize a reporting process for those participating in an alternative payment model while continuing to encourage increased participation in those models. So that means if you're an ACO using web interface, you've got to have a plan to move to all patient, all payer reporting in a way that allows you to be successful, ideally more successful than your peers by 2025. So the good news is that not only has CMS created a gradual phase-in as an incentive to move to MIPS CQMs or eCQMs sooner, but we have a transition plan we walk our clients through that will help break down the effort of this change and alleviate burden by providing you with an experienced project manager, and subject matter experts that are in your corner. Before we discuss the measures, I want to take a quick look at how the end of web interface changes your quality monitoring and reporting. So as an ACO and participant in the Medicare Shared Savings Plan, you've been reporting using the web interface. Now, this method requires ACOs to report performance for a sample of their attributed Medicare beneficiaries. So let me highlight that sample, right? I'm sure you're all familiar with this, but CMS identifies eligible patients for each measure and provides a list of those patients, right? So let's just think through this quick. The list is often long, and you have to report the first 248 for each measure on that list. So this is typically managed as a manual process where once the patients are identified, you have to go to the patient chart and evaluate if the patients met the measure or not. Once this work's complete, it gets uploaded to a spreadsheet, and that spreadsheet gets delivered to CMS. The patient list, however, doesn't get provided until the January following your performance year. So it's really a retrospective process. If a patient's not met, it's just too late to take any action or obtain improvement on that patient for the year. So this method's been around for some time. And while there are definitely some advantages to it, it's probably time for a bit of an upgrade. So when we move to MIPS CQM, eCQM reporting, that uses the MIPS rules. Now here at Mingle, we're really familiar with those rules, and it means that you'll now be looking not only at your Medicare patients, but all qualifying patients based on the measure specification across all payers. This means your denominators will increase and expand. So there'll be an increased number of patients, certainly, but also because we're looking at all payers, your patient populations are going to expand beyond the 65 and older group. So let's take a minute to think about that 18 to 64-year-old population as we look over the measures. Here's the total list of measures required for both the web interface methodology and the MIPS CQM or eCQM method. We've also added a green check mark to the measures that are outcome measures, because understanding your outcome measure options is going to be really important for 2022. And Amy's going to talk about that shortly, along with our recommendations for how to make that transition work for you. You can see, though, starting at the top, you're going to need to consider the CAPS survey, which is going to be using the CAPS for MIPS scoring, the 2 claims-based measures that CMS is going to calculate for us, and under the web interface, we've got 10 quality measures. For the MIPS CQM or eCQM option, you're only going to be looking at 3 quality measures: hemoglobin A1C, poor control, depression screening, and high blood pressure. So on one hand, CMS has streamlined this quite a bit, right? On the other, because we're looking at all patients, all payers, we're looking at more eligible instances to evaluate. Now, that doesn't just impact the documentation of care, but the actual clinical care and interventions that are being delivered. How your clinicians treat a 70-year-old with diabetes is just likely to differ from their approach with an 18-year-old. And their approach really does need to be best practice and customized for that patient segment, because if we treat an 18-year-old like a 70-year-old, you're not going to get the outcomes that you want. So when we talk about these quality measurements, we feel it's really essential to have somebody in your corner who understands the measures. The MIPS CQMs and eCQMs may have the same titles, but the versions of each measure have subtle yet important differences. It's also helpful to have a partner in this who can analyze all of your data related to eligibility and performance, because not all performance issues are related to delivering poor care. Sometimes it's a data problem or even a documentation workflow issue. Solving the wrong problem just leads to wasted effort, frustrated clinicians, and honestly tends to generate mistrust of the EMR that's there in the practice. At the end of the day, what matters to your stakeholders are your results. So Amy's going to talk a little bit about what the path forward looks like for organizations like yours.
Thanks, Allison. So what is the path forward? First, I'd like to address an issue with reporting eCQMs. So many ACOs believe they can simply use the eCQMs or QRDA3 files generated by their member practice EHRs and simply add the results together for their ACO submission. That is not correct. eCQMs need to be calculated and reported at the ACO level in a single record that includes all member participants and deduplicates patient data. Therefore, eCQMs are only an option if an ACO has an enterprise EHR that all member groups and participating providers are using. According to NACOS, which is the National Association of ACOs, multiple EHRs is the norm. There's an average of between 36 and 436 TINs per ACO. 40% of NACOS members say they have more than 15 EHRs within their ACOs, and there's even one MSSP that has 422 TINs using 65 different EHRs. With these statistics, most ACOs will not be able to report using eCQMs and will instead need to engage a registry to report CQMs. This method provides more flexibility, and Mingle has developed processes and tools to aggregate data from multiple sources, normalize it, and deduplicate patients to calculate measure results that are true, accurate, and complete. So let's take another poll. How many EHRs do you have in your ACO or health system?
Thank you so much, Charles, for running these polls for us behind the scenes.
Yes, we've got most people have weighed in. Let's give them about 10 more seconds here so we keep the presentation moving.
And you don't have to know an exact number, just take a guess.
right. Thank you all for sharing. Just going to share that back with the group here. We do have a set of folks who are believe that there's a single EHR within their ACO organization. But the second most common answer was more than 10 EHRs. So really what we are learning from the organizations that we serve and are speaking with is that most of you have lots of different systems with lots of different capabilities.
That's
All right,
fantastic.
back
And
to
for
you.
those of you, I'm just going to pop in real quick. For those of you with one EHR, since we did have some people respond that way, another thing to think about is it one instant of the same EMR across all of your member practices, like everyone's on an enterprise, or is it just they're using the same vendor? Because if they're using the same vendor, you still might have similar EMR combining issues. Okay, sorry. Back to you, Amy.
All right, that's okay. All right, I know some of you want to jump right into talking about what data we will use, so here we go. So this graphic here displays the various data types we accept while allowing flexibilities for organizations with differing technical resources. So we start with your denominator data. This determines your eligible patient population and is based on the demographics of the patients you see and the ICD and CPT codes you use to bill for their services. So our preference is to get 837 files, which is the standard electronic file submitted to clearinghouses by most billing companies. While this method works for most clients, there are some outliers. So we also have the ability to take a practice management export that meets our specifications to provide flexibility in retrieving this data. So then we move on to numerator data, which is used to report performance on measures for your eligible patient population. This can come from a number of reports that can be extracted from your EHR, such as QRDA1 or CCD files, or just analytics extracts that you could run, say, like an A1C report or a vitals file. We can provide flexibility to organizations who don't have those extract tools within their EHR. We can translate quality data codes to aid in performance reporting. We can also provide patient lists for practices that are still on paper and will need to do manual chart abstractions. We are designed to meet your member practices wherever they're at. There is a continuous data flow cycle of import, validate, and calculate that occurs over and over. It will take some work to initiate the collection of all payer data, but once it's established, you'll find it evolves into a natural cadence where the focus then shifts from just capturing the data, but to improving it. So, how can Mingle help? Our experience has proven that results come from relationships. Working with Mingle is truly a partnership. Our solution is not software alone. We combine our cloud-based technology with our expertise to meet customers where they are and drive results. Every customer is assigned a dedicated project manager / consultant who cares about the success and serves as their primary point of contact throughout the project. We know your ACO membership can range from large health systems with multiple billing companies and EHRs to one-doc shops still on paper charts. At Mingle, we already have proven our success in helping organizations of all sizes as they move from Medicare-only reporting of PQRS to all-payer reporting in MIPS. This experience has proven the need for flexible data acquisition EHRs across multiple EHRs and billing systems without the complex and expensive integrations. So we accept industry standard healthcare data formats and work with our clients to tap into their available data sources. A member of our clinical informatics team will also be dedicated specifically to your data. Working together, we usually discover that the question isn't about if the quality action is performed, but rather where is it stored in the EHR. Understanding the relationship between your clinical team workflows and technical team report writing will improve both data retrieval and performance. A delay in CMS's retirement of web interface is a gift of time that you must take advantage of in order to ensure success. Let's get started now. CMS's delay is the head start you need. There are scoring incentives for those organizations who transition starting in 2022. The switch to MIPS CQMs does significantly increase the number of eligible patients for reporting. However, it also gives you much needed insight into your entire patient population and moves you from reactionary reporting, getting the patient list in January after the performance year is over, to a proactive quality monitoring of all patients where improvements and interventions can be made within the performance year. This shift creates the opportunity to make improvements that matter for your organization and its members. Benefits to starting early. So here you can see that the quality performance threshold for web interface remains unchanged at the 30th percentile for 22 and 23. This means that you'll need to have an average performance in the 30th percentile across all 10 web interface measures. However, the quality performance thresholds for MIPS CQMs are reduced to encourage early adoption, which means you'll only need one outcome measure to achieve performance in the 10th percentile and any one of the other 5 measures to achieve performance in the 30th percentile. All payer data retrieval is complex, especially when there are multiple data sources. While the initial effort is significant, once it is established, it tends to run like a well-oiled machine. Using this gift of time to execute your collection of all payer data in advance of program requirements will allow you to know ahead of time that you have the data you need. Then you can solely focus on quality improvement and will be prepared for future increases in quality performance thresholds. This will prevent you from falling behind other ACOs doing this same work. So let's map out your path to success. We recommend spending 2022 working to capture your all payer data from the various sources within your ACO. Identify any missing gaps or where clinical workflows and technical report writing do not align. Working with Mingle, you'll have your consultant and our clinical informatics team to guide you through this process. It's not unusual for all payer data capture to take 6 to 9 months to initiate. That's why taking advantage of the head start is so important. We also recommend establishing an ACO steering team that is committed to member practice engagement and accountability. This is especially important if you have carried the reporting burden for your member practices in the past. With the move to all payer reporting, members will need to actively participate in quality monitoring and improvement. This team should include representatives from billing, clinical, and technical departments. Remember, relationships drive results, so having all these areas represented and working together will help you achieve your goals faster. This steering team can also introduce flexible alternatives for data collection, such as QDC coding and patient lists for practices with limited technical resources or paper charts. If your organization can meet the requirements for success in 2022, take advantage of the reduced quality performance thresholds and report your CQMs. You also have the option to report the web interface measures. Reporting both allows CMS to use your best score. Next, dedicate 2023 to any remaining work needed to completely capture your all-payer data. Once you've validated that data capture is complete, a cadence is set to continue the flow and focus is shifted to improvement. Sometimes just the visibility of the data alone will drive that work. Improvement also comes in the alignment of clinical workflows and technical data queries. Making sure clinical staff are documenting in the right place or checking the right box ensures accurate representation of the work they are doing is reflected in the data. Your members will be able to access their quality data themselves from the Mingle dashboard. We can also help your member practices with their group or individual promoting interoperability submissions and provide your ACO with that data in advance of your annual feedback report. This brings us to 2024 and you are ready. The requirements are the highest they've ever been, but your head start prepared you for success. Now you can expand improvement to other areas. Mingle has tools to help beyond quality reporting, such as streamlining patient assessments, including the annual wellness visit, track patients with multiple chronic conditions, improve reimbursements for preventative care. We're working now to prepare even more tools, such as population health, commercial payer quality programs, and HCC coding.
And I just wanted to pop in real quick here. One of the things I love about this path to success, Amy, is that we've really laid out, yes, let's capture your data now and compare it to what you're seeing in your web interface, right? We anticipate that at least the first attempt that a lot of ACOs make at this, web interface scores are going to score higher. That doesn't mean don't do it right away, right? That means you have to have both in front of you in order to make that decision. And then through that process, that helps us improve.
Exactly. All right. So in summary, here's what to expect from your partnership with Mingle Health. A dedicated consultant and clinical informaticist committed to the success of your organization. We help you set goals, execute a project plan designed for success, and provide expert perspective and guidance along the way. We can combine data from multiple sources and systems and have the flexibility to work with your members from high-end EHR users to paper chart practices. Our tools allow you to view your performance from the ACO level all the way down to patient level data. We can also help you track and improve additional measures that align with other programs you may be participating in. Most importantly, a partnership with Mingle is one that gets results. Working together, we will help you understand your data and how to harness it to improve what matters to your organization and its members. Back to you, Allison.
Great. Thanks so much, Amy.
Sure.
So we hope we provided a lot of information, at least briefly, today for you about this change. Beyond quality alone, Mingle Health is your partner to succeed with value-based programs. So really what we have is a variety of flexible solutions that allow you to first aggregate data from a variety of sources, right? Analyze the measurements, identify and prioritize interventions, and we're experts at engaging member practices and clinicians from just our experience that we have with working with groups of all sizes over the years. So the idea is we want to provide the benefit of our expertise, our analytics, and our advanced care management tools. But now that you've heard a little bit about us and a little bit about the rules, let's do one more poll. When is your organization planning to start your transition?
All right. I've got answers coming in quickly here. Thank you everyone for sharing your feedback. And this isn't a test either, so just gut feeling of where you're all at. Would love to hear. Any hunch, Amy, which one's in the lead at the moment, or Allison? So basically we kind of gave the option is as soon as possible or only when I absolutely have to on two ends of the spectrum here.
I think with we've encountered a lot of practices at both ends of that spectrum, interestingly. So I don't know, it depends who showed up today.
Yeah, and when we step up from the practice level to health systems and accountable care organizations that are, hopefully, I think the results show that we've got a little bit more of a proactive audience. So here we are. I'll share the results back. We really have a mix. Some folks are really feeling like they need to start the transition as soon as possible, 32%. And many folks still are looking to start that transition within a year, 35%. 10% are holding out for only when they absolutely have to. And we understand the need, and there's lots of priorities and stress on our organizations, particularly with COVID. So we've got a whole mix. Thank you all for sharing.
Thanks, everybody. We've got some questions that came in advance.
Yes, and we've got a few as well that have come in. We had one comment that I'll share with you is we had a question / comment from Rick. Thank you, Rick. Nice to see you on the webinar. Sharing that the 30th percentile for web interface, it's not only the 30th percentile for all measures, but also for all MIPS quality category scores, underscoring that it's a much higher bar for web interface. So maybe you could just reiterate or comment on how high is the bar across those two options.
Amy, do you want to take that one?
Sure. Yeah, it's a big leap. That I think it's another reason to take advantage of going the CQM route, because you're only required to have one of those outcome measures hit 10th percentile, and then any one of the other 5 to hit the 30th percentile. So, but of course, come 2024, both the web interface and the eCQMs quality performance thresholds equal. So it's just really all about, can you take the next 2 years to practice to ensure you have what you need by the time you hit 2024, where the requirements are the same regardless of which method you use. So yeah, it's getting harder, and I think that's a trend, unfortunately, or fortunately, will continue. So yeah, it's definitely, it takes some effort. It's not something that can necessarily just happen overnight, which is why we encourage using the time wisely that CMS is given.
Sounds good.
Absolutely. All right, well, folks are formulating their questions. Just a reminder, this session is being recorded and the slides are going to get sent out later this week by email. Let's go ahead and dive into the questions that we got in advance.
Okay. So Susan asked, I've been told that the ACO has to report 70% of the patients, but is there any benefit to reporting less than 70%, for instance, if there's data access issues? Amy, do you want to answer that one?
Sure. So thanks, Susan. CMS's data completeness criteria does require to have at least 20 eligible patients for a measure and a reporting rate of at least 70%. So just using easy numbers for math, if you have a measure with 100 patients that are eligible, and you've reported on 80 of those patients, then you would meet the data completeness criteria because you've met the 20 patient minimum and you have reported on 80% of the patients. So our dashboard will display both your reporting rate and your performance rate. So as you're working on your data throughout the year, you'll know where you're at based on how much billing data we have so far. You are required to report 100% of your denominators or your eligibility for each measure. So we'll confidently know by the time we have all your billing data for the year if you've reached that 70% of the numerator or not. CMS is very strict regarding data completeness, and they don't want you to just choose 70% based on who your high performers are, as they would consider that to be cherry picking. But there is the option that once we get to the end of the year, and if you've hit that reporting threshold, then you could make the determination, do you want to continue to report on, say, that Q4 piece performance to just further enhance your numbers, or if some practices just need to save time to focus on other things. It's really more of an individual member by member scenario there. But data completeness is required for all 3 MIPS CQMs that are submitted.
Thanks, Amy. Our next one is from James, and he asked, if an EMR is certified, does that mean they'll be able to get me a QRDA file of the eCQM measures? So thanks, James. We work with a lot of EMRs. We work with a lot of certified EMRs and EHRs, and I think you'll find that there is variability there. So in many cases, when organizations are looking to aggregate and submit using eCQMs, as sort of a knee-jerk reaction, we think that a certified system should be able to easily generate a QRDA file for submission. The truth is that it really depends on what your member practice relationship is with the EMR, what they've purchased, what they've licensed for. And just because the EMR is a certified system, that doesn't mean they're certified to report and export each specific measure, or that you'll get the exact file you need out of the system. Partially, this is because not all EMRs are certified to report all available CQMs. Now, these 3 are more common than some of the others, and so that should be less of an issue, but it's also partially because licensing agreements vary customer to customer. So again, there's not a whole lot of context necessarily with this question, but remember that if you have more than one EMR across your ACO, or even more than one instance of the same EMR, you need to report the registry version or the MIPS CQM of the measures anyway, because those QRDA 3 files show group performance for only that practice, and it's sort of siloed there in the EMR. So CMS has really clearly stated you can't just add the performance of those QRDA3s together. Now, registries have been established specifically to do this work of this aggregation, deduplication, analyzing. I can tell you that here at Mingle, we do use QRDA1 files as a part of that aggregation. We can, if it's something that are easy for you to get, because those are patient level files. And so we have a lot of internal tools that allow us to mine those files for clinical information. Just to go back to the core question, however, which is, can you get that file? And we've definitely found certified systems that don't and certified systems that can. It all comes back to the agreement. The good news is that we've got experience with a lot of different systems. And if you can't get the file of your first choice, we always have plan B or plan C, and just sort of work our way down to get to the data you need. It can be a challenge, but we make sure our clients aren't alone. There's always another path that can lead you to success. Here's another one, Mary. She asked, what advice do you have for engaging clinicians and member practices around documentation and workflows to make sure you're getting the right clinical data in place that you need to support that performance? Amy, do you want to do that one?
Sure.
Okay.
We mentioned a few times that results come from relationships. That's not just your relationship with Mingle, but also the relationships between your billing, clinical, and technical teams. Your Mingle consultant and clinical informaticist will meet with you to review your data and discuss the findings. Through this review, we'll often find that a clinical workflow may need to be adjusted, such as checking a box or documenting in a specific field, or that a technical query needs to be adjusted to pull results from another source. We know it takes time to implement changes to workflow. That's why it's important to have an ACO steering team with representatives from each of these areas. This team can set goals at the ACO level and then reinforce them as they engage with their member practices.
Thanks. I really like this one. So Frank asked us, how do we see our denominator patients if we don't bill out of the same system that we document in? We're working in 4 different EMRs for 2022. So right, they have EMRs, not EHRs. There's no billing component to it. They've got a separate billing system. This is kind of the core challenge right here. And these are exactly the same kind of challenges that we worked on and solved since the PQRS program transitioned into MIPS. So in this specific instance, what we do in that case is identify the eligible instances and associated patients first by obtaining either that X12-837, the pre-adjudicated claims, or a flat file like Amy talked about of practice management data. What we do is cross-reference the data there. So the patient name, date of birth, and other identifiers, along with data needed for eligibility, right? And that's all laid out in the CMS MIPS specs. So there's usually a CPT for a patient visit, billing NPI, a visit date, and this kind of works in combination with the ICD-10 code. And we can actually compare it across the measures you're looking at, so it'll generate a comprehensive list of eligible instances for you in the system. So for that ACO leader, once we've got the billing data flowing, you're going to be able to easily see your denominator patients, your number of eligible instances at the ACO level, the individual practice level, and really all the way down to each individual clinician. Hopefully that helps. Here's our next one. So Jim asked us, what does the timeline look like for an organization to get ready to report using MIPS CQMs? Can we get it done if we plan to start in 2023? And Amy, since we're taking turns, you want this one?
Sure.
Okay.
So waiting to start until 2023 gives you just 1 year to prepare for the program's most difficult performance thresholds in 2024. While it's not impossible to work on capturing your data and performance improvement at the same time, an extra year of preparation helps ensure your success. I like to use funny analogies. So think of it like going on a diet for an upcoming vacation. Will you get better results if you start your diet now, or if you wait till the night before you leave and just pray you wake up then? So it's, you know, just the more time you have to prepare, the more time you have to be successful. Keep in mind that there's also a paperwork piece to any new relationship. If your organization is ready to start this work in 23, let's begin those conversations now so that contracting is completed by the time you're ready to start the work. Let's take advantage of all the time, the gift of time that CMS has given us.
Yeah, it's an excellent point, Amy. Really, the more complex your organization is, you guys know that contracting piece tends to just be a little more complex as well.
Yep.
All right. So Jeff asked us, what are Mingle Health's capabilities beyond quality measures? How can you help us succeed as an ACO? I think this is a really fantastic question. I encountered when I went to NACOS a lot of organizations that are really looking to try to put together kind of a whole house solution, or at least to have a whole house expert with them, right? And we are really seeking to be an agile partner with you through your value-based journey that your organizations are on. We're incepted in 2012 and have worked with organizations of all sizes. So we're experts at member engagement, which is going to be key as you move into all patients, all payer. Implementing care management programs, which is a big piece of being successful as an ACO, and really driving those improvement initiatives. The idea is getting insight into your data really drives where we help you and how we collaborate. Again, to Amy's point, it always goes back to the relationship, right? Build a relationship with us. We talk about where your pain points are. We talk about where your challenges are and solve to that. That is the end of our pre-submitted questions. Charles, did you have any others that were out there?
Yes, I got a couple questions related to what does it take to engage member organizations that are part of the ACO, both in the quality metrics, but then broader in what it takes to be successful. So I'd love both of you, I think, come from this from a slightly different angle. So I'd love to kind of hear both your responses of your thoughts on member engagement to achieve this work that you've been talking about.
Yeah, absolutely. So when we have discussed this with our ACO clients, we really find that ACOs are positioned in a couple of different ways. One, they either would like us to help them in that engagement, and so we're meeting along with them with member practices, or two, they really want to be the ones who are presenting themselves as the experts to the member practice, right? And in that second case, we can really function in either capacity for us. We really do like to make you guys look like the rock stars when it comes to your member practices, but we understand that there are some who are open to a more in-depth relationship. And the nice thing about either way that we position this is we can take the goals that we discuss with you at that ACO organizational steering level and really make sure that they get communicated down into those member practices so that everyone's driving toward the same thing and everyone understands why we're driving toward the same thing. Amy, do you have anything you want to add, throw into there?
I mean, I think it's just kind of an over communication effort that needs to happen in both areas. So whether that's at the ACO level or the member practice or both, you tell us how you want us to assist and we're there to help support that work.
Yeah. And even for those of you that have smaller practices do tend to have slightly more challenging EMRs if you haven't encountered that already. And that's part of where our years of expertise working with practices of all sizes really does help, because our team of consultants has really pulled together a large amount of expertise surrounding how these EMRs work and what kinds of data we can get out of each one, and we've just seen it again and again. So if you come to us and say, hey, I've got 30% of my practices on ECW, well, we can tell you, okay, well, this is our experience with ECW. So I think that those sorts of insights really help along the way.
That's great insights. Thank you for sharing. Just as we look to the final few minutes here in the session, What would you both underline as a key takeaway for organizations to be thinking about as they're looking to make this transition? One takeaway that I'm always appreciate seeing in there is that folks can submit their data multiple ways and get the highest score. So I think that that's a really important, almost low risk way to kind of get going. And the sooner you start, the better, because you can make use of it and, perhaps get the highest score possible. What else would you guys share as a takeaway with the audience as we go ahead and wrap up here?
I think that I've had a handful of people that are not analysts, people that are not data analysts, right? So they're working at the ACO, but they're working at a higher level. Ask for, they're looking for solutions that are things that are like interfaces, right? And APIs and ways to get that data like smooth and flowing. And that is one way to approach it. The approach that we have found that works really, really well is a less expensive approach, and it requires less maintenance long term. Because if you think about every time the EMR has an update, now you're going to have to go out and update that API. Now you're going to have to revisit with your analytics team again, right? It's a constant body of maintenance work. And we can certainly talk about those sorts of solutions for anyone out there who's interested. But my gut wants to say to you, take a look at our project plan first, because I think that it is a simpler, more straightforward way to get the same data that you need analyzed. I'm just kind of a data nerd by heart, so that's part of it. Amy, how about you?
I just think it's initiating your project now. Whether that's just discussing, kind of internally, what's your plan, but just setting up the plan, making sure you have one, and then just begin the initiation of it. So much insight comes from when you make this transition because you're seeing your entire patient population. You're seeing where improvements can be made. Kind of to piggyback on what Charles said, you could submit different ways. Some of your high performers could also submit MIPS measures, and CMS again will use the best scores. Starting early just kind of allows you to eat the elephant one bite at a time versus waiting until it's required and you got to do all the things at once. So it's just sometimes easier to, okay, I'm going to focus on data capture, then I'm going to focus on improvement. And then once you have those flowing, you have the flexibility to work on what's important to you, and we'll help you figure out ways to improve that, whatever that may be. So it's just, the key is don't wait, start now.
You can tell who the project manager is in the group.
I think those are just terrific takeaways. So, and a great place to end for today. So I want to go ahead and say thank you to everyone who joined us. If you have questions as a follow-up, we're here to help. I hope you got a taste from hearing from Allison and Amy that Mingle is right there at the intersection of technology and expertise. And when you work with us as an organization, we're going to guide you through these programs. We're going to be your agile partner to bring that expertise to your organization, to your members, to help you make sense of your data and understand where to go from there. We understand that it's not one size fits all, and that's what we really enjoy doing with the customers that we've been able to serve since 2012. So with that, thank you all for joining us. Allison, Amy, thank you for sharing your knowledge and insights with everyone, and keep an eye out for the recording and the slides later this week.
Thanks, everyone.
Thank you.
All right, let's go ahead and close it down and we'll be all set.